Dear friends and ladies and gentlemen, the next topic in the top 10 video lecture of basic laparoscopy, we are going to discuss the management of common bile duct stone in the era of minimal access surgery. Next slide. There is a 10% chance of common bile duct stone in patients with gallbladder stones. 1 in 10 patients with gallbladder stones can harbor bile duct stones. How to recognize them? Next slide. The gallbladder stone can present clinically with either intermittent pain, fever, jaundice, what we classically call as a Charcot striate, or sometimes they can come to the ICU with confusion, hypotension, septic shock, like what we call Raynaud's pendant, and it is one of the common cause for obstructive jaundice. Biliary pancreatitis is yet another clinical presentation, but often large majority of the patients with a bile duct stone can be asymptomatic. Next slide. The bile duct stones are much more dangerous than gallbladder stones because of risk of cholangitis and also risk of gallstone pancreatitis, because both these conditions are lethal. Next slide. There are at least 5 different investigations available which can confirm presence of bile duct stone, namely ultrasound abdomen, CT abdomen, MRCP, endo ultrasound and ERCP. Next slide. Coming to the ultrasound abdomen, though ultrasound abdomen is very sensitive in picking the gallbladder stone, when it comes to the bile duct, its sensitivity drops. So only 60% of the bile duct stones one can identify by an ultrasound, even though it is a non-invasive and diagnostic. Because of the lack of sensitivity, we can't rely. So a normal ultrasound cannot exclude a small common bile duct stone, but one can presume presence of common bile duct stone if the sonologist gives a report saying that the common bile duct is more than 6 millimeter diameter, because the normal bile duct is about 4 to 5 millimeter. Any bile duct more than 6 mm should be taken as a dilated bile duct, and it itself is an indicator of probable stone in the bile duct. Next slide. So the best investigation, of course, is the endoscopic ultrasound, but it is invasive, it is only diagnostic, it is highly operator dependent, and available in only in few centers. So because here the ultrasound is at the very end of the endoscopy, so it is very sensitive and is able to see each and every layer of the bowel, and also it can accurately locate the bile duct and pancreatic duct, and any sludge or even microlithiasis one able to appreciate. And because of its operator dependent nature and invasive nature, not in each and every situation we will be able to use. Next slide. CT abdomen, especially the spiral CT, is quite a sensitive and specific investigation to delineate, and we can get a very nice CT cholangiogram to look for any bile duct stone, and also it is an ideal investigation in a case of obstructive jaundice to exclude any mass lesion in the head of pancreas, like a head of pancreas growth or a periampullary growth or a cholangiocarcinoma. Next slide. But when it comes to the best investigation, our money is on MRCP. This is the test of choice, because it is not only non-invasive, it is very sensitive, and there is a 95% chance that we will not miss a stone in the bile duct. So as you can see in this picture, there is a solitary stone in the bile duct, and you can also visualize the pancreatic duct. So the MRCP is the test of choice. ERCP at the same time is a treatment of choice. Though it is invasive, it can be used for a therapeutic potential. Next slide. ERCP, like its 4-letter, it is a 4-team work. That is endoscopy team with the experienced endoscopist, and radiology team with a radiographer or radiologist, and anesthetist is there always at the head end, because the patient is most often prone position and it is a prolonged procedure where you need to have a close monitoring of the patient, and you should have an excellent nursing team to give you the appropriate accessories to perform this procedure. Next slide. As you can see in this picture, the side viewing scope enters the second part of duodenum, where on the medial wall you can see the convergence of the bile duct and pancreatic duct. We should be able to identify the ampulla and put the appropriate accessories like a sphincterotome or a cannula to inject the contrast, and we should study the bile duct and pancreatic duct. We should be able to selectively enter bile duct and do the necessary therapeutic procedure. Next slide. So ERCP is an endoscopic evaluation of the upper GI tree and a radiological evaluation of the bile and pancreatic tree. And as you can see in this picture, sometimes you may be able to notice impacted stone at the ampulla itself or pus pouring out in a case of cholangitis. And this still picture of cholangiogram clearly shows bile duct, pancreatic duct, and also very tortuous cystic duct and gallbladder. Typical hockey stick appearance of the endoscopy is seen. ERCP requires a very special side viewing endoscopy which has additional gadgets like an elevator, and the side viewing scope allows the surgeon to see the side of the duodenum. It is like a bird or a fish having an eye on the side. It is able to see the side wall of the duodenum clearly, and through this side viewing scope one can put various accessories, namely the sphincterotome, balloon, baskets, and do various therapeutic procedures. Next slide. The various therapeutic procedures are explained in this picture. As you can see, the center of the video demonstrating what we call a sphincteroplasty. That is, a CRE balloon is passed through the ampulla, and when the balloon is inflated by inflation device, and it can be inflated right up to 15 mm even in a patient with a dilated bile duct with a stone, then we can pass a wire guided basket or even a biliary balloon, and when we just grab the stone or pull the stone, and the stones very easily pass through the ampulla into the duodenum. That is the easy way to remove all these stones in the minimal access way. Sometimes we can selectively cannulate the bile duct and do what we call a sphincterotomy. The sphincterotomy is a technique wherein a wire guided sphincterotome is passed into the bile duct, and the sphincterotome is armed with a bow like diathermy wire, which when it is tightened and applied monopolar current, it enlarges the ampullary opening from 1 mm. It can enlarge to even a centimeter or more, but one has to be very careful when we divide and cut the sphincter, that there should not be any undue bleeding, and there should not be any risk of perforation or pancreatitis. For this we should use an endo-cut device, which is a special diathermy device available in all newer versions of diathermy like Erode and Valley Lab. And we should know the Fogarty biliary balloon, and also the use of the lithotripsy, mechanical lithotripsy, wherein we can pass the basket and we can pulverize the stone, take the stone bits. So these are all the various therapeutic procedures we perform in the ERCP. Next slide. This ERCP picture shows a dilated bile duct with a solitary stone in the lower end. Next slide. This ERCP picture shows a large CBD stone, a square shaped stone, which usually requires mechanical lithotripsy. Square stones usually indicate the stones are very hard to break. Next slide. This ERCP picture shows multiple stones in the bile duct, and as you can see in this video, the ampulla is entered by a bow-like wire. There is a sphincterotomy. The ampulla is surrounded by periampullary diverticulum. The bow-like wire is stretched and a monopolar diathermy energy is applied, and the ampulla is divided and enlarged to the size of a centimeter. Then through the enlarged ampullary opening, one could pass a Fogarty biliary balloon, and once the balloon enters the bile duct, it can be inflated and it can be seen under C-arm guidance where the balloon is. As we drag the inflated balloon, all the stones below the inflated balloon will come out one by one. This is the best atraumatic way to remove all the stones, and we can do at the end of the procedure another cholangiogram, that is called a check occlusion cholangiogram, to ensure that we have removed all the stones. If we are worried about any sludge or residual stones, we can always leave a small biliary plastic stent to aid biliary drainage. So sphincterotomy, Fogarty balloon sweep, Dormia basket, they are all in the armamentarium of any endoscopist in order to tackle a patient with multiple bile duct stones. Next slide. We can go several times into the bile duct and inflate, and to ensure that all the stones are removed and the inflated balloon come out in the inflated position very easily from above downwards. But a word of caution regarding ERCP, it should be used only as a therapeutic modality, because for diagnosing any biliary and pancreatic pathology now we have FRCP. The duct cannulation rate is around 95% in experienced hand, and the duct clearance of bile duct stone is around 90%. As I mentioned earlier, the complications are pancreatitis, bleeding and perforation, and also there is a very small mortality. So one should be very careful in the early phase of their experience to avoid such major catastrophic complications. Next slide. In that case, the options are as follows. The standard of care, of course, is either you can complete the lab chole and send the patient for post-op ERCP, or you can proceed with laparoscopic exploration of CBD, or even consider converting to open procedure and go for open CBD exploration. All the three are acceptable procedure, but of course the commonest method is lab chole and post-operative ERCP. What happens if post-operatively you have a diagnosis of bile duct stone, especially in a patient who had previous cholecystectomy? Then the options are three, namely send them for ERCP or followed or preceded by MRCP. Or if the patient has a T-tube, you can take a picture of T-tube cholangiogram and demonstrate the stone. Let us see in the next slide an interesting case. A 60-year-old man with a 4 months history of fever, abdominal pain on and off. He also gave a history of passing dark urine at least on 2 occasions. So as far as the Charcot's triad is concerned, he had all the criteria to satisfy that the probable cause for his symptomatology was bile duct stone. Following ultrasound, this patient underwent MRCP, which showed a large CBD stone. As you can see in the next slide, MRCP, which usually is the test of choice for a suspected bile duct stone. Here in this patient, he had a hugely dilated bile duct and intrahepatic biliary radicals with a large impactor stone in the lower end. You can also see the pancreatic duct. So the MRCP is a very good, sensitive, non-invasive diagnostic modality to diagnose bile duct stone. Next slide. But if the patient needs intervention, like in this patient, then the patient needs ERCP, and we need to pass the side viewing scope, identify the ampulla which is in the second part of the duodenum. Ampulla is very easy to identify. This is usually situated over the top end of the vertical fold, the only vertical fold present in the second part of the duodenum. Then you can cannulate the bile duct. There are two ducts in the ampulla entering. One is a bile duct and a pancreatic duct. The bile duct is directed towards the 10 o'clock position, whereas the pancreatic duct towards the 2 o'clock position. So we can selectively cannulate the bile duct, and by using a bow like wire guided sphincterotome, we can divide the ampulla and do a sphincterotomy, and as you can see, after that the bile will be draining, and you can pass either a Dormia basket or a biliary balloon in order to remove the stone, and following that one can either leave a stent in order to aid drainage while waiting for a laparoscopic cholecystectomy. Next slide. So next case capsule 2, is a case of a gallstone pancreatitis. This is a young man presenting with a severe abdominal pain, back pain for 3 days. Serum amylase was 2016. Ultrasound abdomen showed multiple small gallstones and a dilated bile duct and enlarged pancreas. In view of the pain, fever and jaundice, the patient underwent ERCP, and as you noticed, the patient had an impacted stone in the ampulla. By using a needle knife, a small tip of a needle diathermy knife, you can lance the ampulla and the stone will pop out like a popcorn, and the patient's symptoms relieve, and it is a very gratifying procedure to do in a case of a gallstone pancreatitis. Next slide. So when it comes to the discussion of role of early ERCP in case of severe biliary pancreatitis, there are a couple of papers in support of early ERCP. One from Neophthalmus and another is Fan et al. And both say that ERCP has a less morbidity, shorter hospital stay, and also minimizes the mortality, especially in patients with biliary pancreatitis and severe jaundice or sepsis. In a very mild biliary pancreatitis, very often the stone would pass spontaneously. In those situations, ERCP is not warranted. All one may have to do is to do an MRCP to confirm that there is no stone in the bile duct before proceeding for laparoscopic cholecystectomy. So, mild biliary pancreatitis, ERCP has very little role. Severe biliary pancreatitis, especially with the jaundice or sepsis, one may have to consider ERCP early enough to improve the patient's recovery. Next slide. Before we conclude, let us enumerate the advances in the ERCP. There are newer types of lithotripsy available. Apart from the mechanical lithotripsy, one can use electrohydraulic lithotripsy or even a laser to blast the stones. And if there is any associated biliary stricture, especially below the stone, one may have to use serial stenting or consider CRE balloon, controlled radial expansion balloon, available to stricture dilate. A choledochoscopy, a mother and baby scope or a spyglass scope also available to enter and have a directly view the bile duct and pulverize the stone. The Rendezvous technique is another technique used in a very difficult or unusual situations. Next slide. Mother and baby cholangioscopy is a very good concept, wherein a side-viewing duodenoscopy is passed right up to the ampulla. Then through the biopsy channel, another fine cholangioscopy is passed. Obviously, a mother and baby cholangioscope examination requires two experienced endoscopists, one holding the mother, another controlling the baby. But unlike this, the newer version, next slide, is spyglass cholangioscopy. In spyglass cholangioscopy, the fiberglass, the spyglass attaches to the biopsy channel region so that we can have a reasonably good view of bile duct, and it has a smaller accessory channels through which we can pass laser beam or even a small forceps to take a biopsy. So it make a investigation and treatment of any biliary and pancreatic disorders very exciting. Next slide. This video demonstrates the spyglass system. This duodenoscope is passed right up to the second part of the duodenum through the biopsy channel. The cholangioscope or a spyglass scope enters into the ampulla. It navigates right up to the middle and proximal portion. If it finds any abnormal area, you can take a direct visualization and a biopsy. And if it is a stone, you can either blast the stone or grab it and pull it out. So spyglass cholangioscopy and pancreatoscopy has revolutionized the management of biliary and pancreatic pathology. You can see that stones are blasted by laser and tumors are biopsied. Next slide. The last advance in the ERCP one has to understand is a Rendezvous technique, where if you are not able to enter the ampulla, then one may have to consider passing a guide wire through the liver by PTC, then grasping the guide wire coming out of the ampulla and doing an ERCP, or by using an endo ultrasound also we can enter the or access the bile duct. So all these recent advances also make the ERCP very exciting procedure to master. Next slide. So ladies and gentlemen, to conclude, our aim is minimal access with maximum success as far as the management of common bile duct stones are concerned. MRCP is the test of choice for management of bile duct stones. ERCP is a treatment of choice. Lab CBD exploration requires adequate training and appropriate equipments. So it will be only applicable in a very select group of people, and especially in our country we do more of a CBD exploration rather than a transcystic exploration, and the bile duct stones need special attention and specialist attention. Thank you.